Hi, I'm Dr. Keith North from Sports Orthopedic and Spine in Jackson, Tennessee. In this module, I will introduce you to the basic principles of arthroscopy. This is intended to be a generic arthroscopy setup and demonstrate standard equipment for shoulder and knee arthroscopy. It is not intended to recommend any specific company. I will demonstrate the optics of the arthroscope and guide you through setting up the tower and use of typical hand instruments. I will also show you room setup, draping techniques, and ultimately portals for basic arthroscopy. Here we have a typical arthroscope. The components essentially are the camera body. You have a focus ring. This is the main arthroscope. It's an optical tube. Here you have your light source input. You can see that the tip of the arthroscope has a glass optical lens, and you want to take good care of that. And around the edge of it are the fiber optics. If you touch that tip with the shaver, you'll damage that or scratch the glass, and your picture won't be as clear. You have various buttons on each scope, and they can be different from camera to camera. You do have picture on this side. You have white balance on this side. Now, white balance only works when you have the light source turned on. If you do it without the light source, you're not adequately balancing it. And then you also have the ability to zoom or back out. The picture button can also be used for video. In most situations, it's set up with one press, takes a picture, hold it, and you'll hear a double beep, and that is when your video starts. Now we're going to connect our light. I want to make sure that that's tight because that will frequently fall off. If you look at the light points away from the light cord. This is a 30-degree scope, so the light is pointed in that direction. When we rotate this light cord, you can see that the light also rotates because the lens is pushing that light out 30 degrees. That's the tilt at the end of the camera. So you typically have either a 30 or a 70, and that's going to change your picture. You see straight ahead, but you also see more to the side, and it's to the side opposite of where the light cord is pointing. Another critical point is to realize that the cord coming off of the camera is also your horizon. So if you have that straight up and down, that should be horizontal. And if you go this way, you should be more vertical. And we're looking to the left right now because our light cord is to the right. So now as we turn, you can see the arrow on the screen shows you the direction that you're looking. So the 30-degree light and optics are going to the right, whereas the light cord is to the left. Okay, if we want to look straight down at an object, we put the light cord straight up and it makes it look down at it. This is our 30-degree scope. Now, to take this apart, it disassembles right at this silver ring, and then you can turn and it basically unscrews. Now this whole system should be sterile, but there are some systems where it's not sterile on the inner portion, so you have to be careful in the OR with that. Now we have a 70-degree scope to show you the difference. So it switches just opposite of the light cord, and it's angled 70 degrees, just like the optics are angled 70 degrees. So you're looking straight ahead and kind of around the corner to 70 degrees. Now when we look at that same ball, first we'll start by looking down. You can see your reference point is a little different. If you're very close to it, it doesn't look quite the same. And the amount of movement when you turn, you actually lose some of your field of vision and have to come back a little in order to be able to see it. Whereas with the 30-degree scope, you didn't have to back up as much to see it, and you have to actually turn your scope a little bit more. You do get a better view, and it's very good for looking at things like the anterior glenoid rim from posteriorly, or looking down the rim of the glenoid. So now, let's show you what we were looking at before. Here we're having a hard time even seeing in that because we're looking so far down at 70 degrees, and look at the angle difference. We're not looking through the hole at all. We're actually, there you can see in a little bit, and then as we rotate back, we actually again look so obliquely at it that we can barely look into the hole. But it does allow you to look at the side much easier. So that's the principle of a 30 versus a 70 degree scope. As we mentioned, some of these buttons on the camera itself may be a zoom. In this case, this one is set up for light intensity. So as you push this button, you actually increase your light intensity, and as you push the other button, you decrease your light intensity. We have an arthroscopy boom, and we have all of our arthroscopy boxes stacked up so that we can readily access them. And we're going to go through the connection portion. Okay, first off, here are the on and off switches for each of the boxes. So you want to make sure that those are on. This is just your standard Bovie system. Here we have our pump. So if we start with the camera, we'll hook that up first. And you can see most of these connections have an arrow or a dot in order to indicate the top portion. So this is an arrow to match to the arrow. Here we have arthroscopy on our monitor. And you can pick other specialties if you needed it, but obviously what we're looking for is arthroscopy. Next thing we want to do, this is our light source. It's a xenon light source. This is a fiber optic cable. Most of them have some type of clamp system to grab onto the light cord. You see there's no screw-in mechanism, but it is notched a little bit. You push that in, then let go, and it actually hangs on tightly to it. This is the fiber optic cable. The light right now is on standby. When we push the button, it goes to run, and you can see the fiber optic cable now lights up. When the camera is just sitting on the table or off to the side, it's important that the light is not up against the towel or drape because it may cause a fire, and that's one of the reasons you have a standby on this system. Next we have our shaver system, and you can see that has a red dot, and we push that in to match up that one. As soon as we plug it in, it comes up 1800. So that's, right now it's on hand control. If we want to attach a foot control, we have our foot control system here. So this would be forward, this would be reverse if you hit the middle, and then it becomes oscillate. Here we have the arrows on our foot control. That plugs in easily. They should all plug in fairly easily. When we plug in the foot control, the green foot on the side lights up here. And obviously you can use pluses and minuses to change how fast that shaver system will work. Next we have our radio frequency device. Again, we look for the arrow. It has the hand control there. Plug that in. It should light up that it's the hand control. And you also have a power setting here. You can go up or down. Most of the wands have a preset. Additionally, they have hand controls. The yellow one here will be cut, and you can see it has a high-pitched noise as you push that. And that's to alert you that it's being used so you don't burn something unintentionally. There's a blue button for cautery, and it's a little bit lower pitched. Now you can also use a foot control for this instead if you prefer. And that box has coag and cut, and you can change the level just like we did on the monitor. Next we have our fluid system. So our pump, first you have to plug this portion on. Then you want to hook this, wrap it around the wheels. That's what pushes the fluid, so it has to be around that area. When you push this down, you want to make sure that's up. You close the door, push that down, and then lock it in place. Once that's done, you make sure that you've got the pressure setting that you want. Typically with a knee arthroscopy, it's going to be 35 to 40 millimeters. And then the flow, we usually like a high flow so it'll flush the blood through quickly. When you're ready to go, you hit start or run, and it says pump on. Now these are connected to your fluid bags that are hanging on the side, and you want to make sure that that's open. And then also on your camera, you're going to hook the tubing to your bridge. Now the bridge is a connector that hooks into your cannula that is going into the shoulder or the knee. So here you have another clamp, and you also want to make sure that you open up the portal here in line so that it will flow directly in. It'll go through your cannula. When you turn your light source on here, you can see it lights up at the tip. Essentially now you're ready to go. So here's our other tower. This tower has the monitor on the top, our pump, radio frequency device, even has a digital color printer on it, and then this has an SDC, which is essentially your image capture system. And then down lower we have our camera hookup and then our light source at the bottom. There are advantages to both. The advantage of the boom system is that you can move your monitors around very easily, and they're totally separate from your cart. Here's our standard setup for the Mayo stand that's right alongside of me, so that I can reach back and forth for the instruments that I need. We start with the skin marker to draw out our anatomy and portals. We use the scalpel to make our posterior portal, and then we use the spinal needle to localize our other portals from outside in. We have different cannulas. This is the metal cannula that we insert posteriorly, and then this connects to the bridge and scope. I prefer to use the blunt trocar because there is less risk of damage to the articular cartilage. Once we are looking inside the shoulder with the arthroscope, we will localize our anterior superior portal with a spinal needle and follow in with a metal cannula with an outflow. The outflow helps clear the field of view, and the rubber dam inside limits the amount of fluid extravasation. The top comes off, exposing the rubber dam. You can push the button to take the metal top off or snap it back on to re-engage it. This cannula also has a metal trocar for insertion. Here you can see when we take off the metal top, it has the rubber dam inside, and this can be exchanged if it leaks. Additionally, we have a plastic cannula. This is a screw-in version. We most often use this anteriorly and laterally. It's excellent for passing sutures and also for tying sutures through. It can be used with a plastic trocar or with a metal handle over a switching stick. Then we have our probe to palpate tissue such as the rotator cuff or labrum. We also have Ratex if we need them. Here's a typical setup for the tray that is directly over the patient for shoulder arthroscopy. Initially it looks a little confusing because we have so many cords. The suction tubing is hooked to the shaver. Once you move that out of the way, you have your radio frequency device. On the shaver you have hand controls, with the gray button being the on and off switch. By hitting the blue button, you can change from forward to reverse. You then hit the gray button again for on and off. If you want to oscillate, you hit the center yellow button and then the gray on-off switch, and now the shaver blade is oscillating. Here's our typical back table for knee arthroscopy. We have our prep solution, then we have our syringe and needle for injection after the case. We have a probe, spinal needle, scalpel, the arthroscopy cannula, and trocar. Then we have our marking pen. Additionally, we have our dressing setup. We have sponges, mastisol, steri-strips, suture, needle driver, pickups, and scissors. We have a tray with other instruments that we may need. Here we have our typical grasper. It is serrated to hold onto a loose body when you close it, and it has a lock on the handle. The lock slides up
to unlock and down to lock it. Here's a straight biter. It has a sharp jaw that you can slide under the meniscus and remove sections of tissue as it bites. Also an upbiter, which is excellent for reaching the posterior horn of the meniscus. As you finish with your surgery, you're going to inject the knee at the portal sites with Marcaine and intra-articularly for post-op pain control. We do use a spinal needle to localize some of our portals. Also note that our scalpel is a safety blade. Here we have our standard back table for shoulder arthroscopy. We have the ChloraPrep solution that we're going to use to prep the patient. We have a traction setup, which also doubles as an impervious stockinette. Then we have our Coban. Underneath we have some blue towels. We have gowns for the surgeon. We have some suction tubing if we need to hook that up. We also have our drapes. If you need to have a drill, we have that available as well. Then we have our tray of additional instruments that we need. First we have an elevator for elevating the labrum or freeing up the rotator cuff. We have various drill guides. Here we have a punch and a tap for inserting rotator cuff anchors. You have a mallet. You also have different types of suture passers for glenoid procedures. Here we have a spear and a drill bit. There's also a trocar for introducing the spear through the soft tissue. These come in both sharp and dull varieties, with the dull being less likely to damage the articular cartilage. Then we have multiple hand instruments. We have a grasper, then a rotator cuff grasper, which is less traumatic to the tissue because it's wider. We have a suture retriever, which allows the suture to slide through as you pull it. Then we have our knot pusher. We have an end cutter for cutting the suture. It also comes as a side cutter, open-ended. Then we have our penetrating type suture retrievers, which poke through the tissue and are able to retrieve the suture and pull it back. It comes in a variety of sizes and angles. It also comes as a right and left with some sets. Next we have a switching stick if we want to change cannulas. We have our standard arthroscopy cannula. Also comes with a trocar, can be either sharp or dull. Then there's the shorter cannulas, which requires a separate bridge, whereas the longer one has the bridge built into it, and it has stopcocks for allowing the inflow of fluid. The shorter one requires the bridge to be twisted and connected, and it follows the L pattern. We prefer the longer cannula for large or heavy patients. It works similar as far as the stopcock for inflow. Then we can have a variety of biters if necessary, and also scalpels. Then we have mastosols, steri-strips, injection for postoperatively, and our dressing sponges. Another item on the back table may be the Wissinger rod, which is a long metal rod with a knob at the end, which can be placed through the arthroscopy cannula for an inside-out technique for inserting a new cannula from anteriorly. Here you can see the Wissinger rod goes through the cannula. We can then poke through the other side of the joint and then bring in another cannula following in the tip of the Wissinger rod. And these should meet in the middle, and then you can withdraw the Wissinger rod, leaving both cannulas in the center of the joint.
First, we're going to demonstrate the use of the hand instruments that you'll find on the typical arthroscopy trays. First, you'll have a straight biter. Now, here with the straight biter, typically you'll come in right through. Takes a nice section of tissue out, and you can pull it out at one time, or you can bite several times, and you try to make a nice pattern out of it. Next, what we have is the small biter, and you can see that this one takes a very small bite, plus it has an angle to it, which allows you to reach up underneath the condyle as you come across, and then it makes it easy to reach that meniscus and get the posterior horn very well. We have some very specialized biters. This is a back biter, and it's a left back biter, meaning the opening is on the left-hand side. And you can see here, that works very well for like an anterior horn. It won't cut straight ahead, but it cuts back towards you. You have the same thing on the right side. So again, you can come in, take a bite of the anterior horn, and pull it out. That allows you to get to those hard to reach places. Now, some other specialized ones, you have angled to the left and to the right. So angled biters let you reach, say if the meniscus is curving over and you want to get part of the body, you can reach across and cut on that type of angle. And then for the opposite direction, you can reach in with the grasper, say for a medial meniscus body, you can reach across and cut easily in that direction. Another type of biter is a left and right biter. This is about a 90 degree. As you're coming at the tissue, you can see you reach across it and take a bite out with that. This takes a small bite, but it does allow you to get exactly 90 degrees from the entry point off to the side. And then obviously this one is to the left. So that's what you're trying to do with the biters. Now there are graspers. Here we showed you a rotator cuff grasper and how large that is when it grabs a piece of tissue or the rotator cuff. And here is a standard grasper, and you can see the difference in what you can actually grab. Also, because of the size, that can cause a little bit more trauma to the tissue. Some of the advantages of the smaller one is it also has a lock on the handle. So, and the way the lock works is you push the lock up so you can open the jaws. When you grab something, then you pull the lock down. It slides down, locks in position, so you have maintained control of it. Now this rotator cuff grasper actually has a ratchet lock on it, so it does kind of stay where you put it. And so when you grab and lock on, even without holding the handle, it still holds the tissue pretty well. But as soon as you push it with your small finger on the partial ring here, it pushes it away. Now here we have a grasper that's open more and it's more pointed at the tips. What this allows you to do is to grab loose bodies easier. So if we have a round loose body, you can see we can grab that much easier, whereas a standard grasper would not work very well for that. So that's the key with this type of grasper. Some people call it a pit bull. Now if you need to pass suture through tissue, you have a couple options. You have either what we call a retrograde suture passer or an antegrade suture passer. The retrograde suture passer, the principle is you would poke through the tissue, grab your suture, and pull it back through. And you can pull the suture all the way through like that. Now this is an antegrade suture passer, and there's various types out there. This requires a needle, which you slide through the opening here, bring it forward, and you can see that there's a little and then a post that you can put that through. And once you get that pushed down, it's now sitting on the post. So when you close, you pull the first trigger, it opens and closes the jaw. Once that's closed, you squeeze the other handle and it deploys the needle. So what we're going to do with that, it comes straight up at you. For the suture that you're going to pass, you would just essentially loop an end of it, snap it through until you feel it actually engage. Then you would come in, and we'll show you, like, this is an antegrade suture passer. So now, here you see your tissue. We'd say this would be the rotator cuff. We could take a good grab of the rotator cuff, and then now we squeeze the handle, deploy it, and you can see it pushes the suture up through it. So you can then use this portion with the hook and grab the suture and then pull it through. Other types of penetrating type suture retrievers can be more of a bird beak style. They are bent more acutely at the tip, which allow you to poke through the tissue, then reach across, grab the suture, and pull it through. Very similar to the other penetrating type suture devices, and they come in multiple angles. You can see this one is about 22 and the other one is about 45 degrees, allowing you to reach different areas.